Professor Lange, Sir, Felix, thanks again for the invitation. Victor, dear colleagues, so that's a provocative question. Do we still need a surgeon? At first, when I got the title, I mixed it and I read, do we need a still surgeon? And I thought that would be nice for change. But I think there is no such thing like a still surgeon, and we will hear it. But the next question was it classic coarctation? That's not a word we use every day, and I think that makes my talk a little bit easier. Classic coarctation is located in the thoracic aorta, distal to the origin of the left subclavian artery, at about the level of the ductal structure. It's an isolated lesion, it's circumscribed, and is typically hourglass shaped. It needn't be, but most cases. What is not a classical coarctation, and if a critical coarctation, or a complex coarctation with a lot of associated lesions, or a hypoplastic arch, or a mid-arch coarctation, or an abdominal coarctation, or a pseudocoarctation, if all these are not classic coarctation, then this makes my talk very, very easy. So that's, of course, not a classical coarctation. That's also not a classical coarctation. And now I would like you to tell me, what's this? Is this a classical coarctation? Some would say yes, but we did an echo and talked to our surgeon, and he said, do this angiogram, please. And if I show you the next slide, that's also not a classical coarctation. That's a coarctation and a blend white garland in the same patient at the same time, and the left ventricular depression was not only coarctation related, but also to the Alcapa, which you can see here. So in these cases, I think we need a surgeon, but I think that's the type of lesions we are very happy to have the surgeons, and where we would invite them to do the repair of the coarctation and of the Alcapa, of course. So, indication for treatment is native or residual obstruction with a gradient of more than 20 millimeters mercury, or arterial hypertension, or abnormal increase of blood pressure as exercise, impaired left ventricular function, hypertrophy, or large collateral arteries. The types of treatment, there are three, if you are, three interventions, and a lot of surgical different treatments. And if you have different treatments for the same lesion, then it can have two reasons. The first reasons would be the lesion is very difficult to treat, has very specific forms, and for every form you need a different treatment, or the treatment is not good enough. So all the time you're trying to find something new because the treatment isn't working so well. That might be said for balloon dilation. We are not completely happy with that, but this must also be said for surgery, because this amount of different treatments for the same lesions must mean something. Then I thought, what is classic coarctation repair? And I think Mr. Quackenbauer is a very, very good surgeon, and he said classic coarctation repair is one that does not extend proximal to the left subclavian artery and might be end-to-end anastomosis, subclavian flap, patch, graft, maybe there's something else, but that's the definition by Quackenbauer. I want to tell you something about balloon angioplasty. It was introduced in 1982 after experimental dilation, not in animals, but post-mortem. And the technique is easy. You go from the femoral artery, record the pressures, do an angiogram, and then dilate with a balloon to the diameter of the pre-stenotic segment. Some make the balloon a little bit larger, and maybe that's one of the questions. If you make the balloon too large, you will have problems afterwards. If you make the balloon too small, you will also have problems. I show you an example. This is a 6-month-old child with severe heart failure. You see the depressed left ventricular function. You see the mitral regurgitation. This child has not an Al-Kappa, only the coarctation. I think you can see it clearly here. That's hourglass shaped. There's no duct. There's no other problem. So that's classic coarctation. You put in a balloon. You get a result, no residual gradient, and then you send the child home the next day. This special child that's now 11 years old, it was one of the first I did in Leipzig when I came back from Berlin. And the left ventricular function is normal, the blood pressure is normal, the echo is normal, and the parents refuse to have an MRI or an CT or a recatheterization because they say, when you see a reason, we will do it, otherwise, when our child is ready and she can decide for herself. The problems of balloon angioplasty is a significant rate of residual or restenosis. And how high the rate is depend on patient age, on morphology, and this restenosis is treatable by repeat dilation. So we would have to have another intervention. Procedure-related death is very rare, aortic rupture is very rare, but there is a significant rate of aortic aneurysm, but also the rate of an aortic aneurysm depends on patient age, morphology, and interventional technique. Femoral arterial stenosis is noted not so rarely, but nobody talks about surgical and, I don't have to say surgical, interventional, intensive care treatment with femoral artery obstruction. There's only one paper in the literature. After 1 week, a 22-gauge artery, femoral artery, 20% of children will have a problem with the femoral artery. That's comparable to our catheter intervention. The treatment of the problems, residual or restenosis, can repeat dilated or a stent can be implanted. Wall injuries, rupture or aneurysm can be repaired by covered stent implantation, and femoral artery stenosis can be treated by heparin or local lysis or some other interventions. I want to show you a second case where you see the problem. This was a 4-year-old classic coarctation gradient 60. We ballooned that. Had a residual gradient of 25, but we left it at that, what we wouldn't do right now. And the patient came back 11 years later. He's now 15 years old. And you see here, that's what we call an aneurysm in this type of patient. That is 5 and 6 millimeters. Here you don't even see it. And he had also a gradient of 32, so we implanted a covered stent and got rid of this problem. So we excluded the aneurysm and reduced the gradient to 0. Stent implantation also has a history. Animal experiments were started in 1991. Then the stents were put in ray coarctation in the same year. And the other things which are very important is that starting with Martin Schneider, he reported this in 2003, later Peter Evert, small stents for little children were developed, which will be able to give way to larger diameters during the growth of the child. Martin called his stents baby stents, Peter called his stents growth stents, but these stents are not commonly available for everybody yet, but they are under development. The technique is femoral artery access. For the larger stents, you need narrow sheaths, you need a long sheath, and if you have a covered stent, you have to take into consideration the origins of the arch branches. You need stabilization techniques to have the stent in the right position, and the balloon diameter should not exceed the diameter of the pre-stenotic aortic arch. The restenosis, of course, in little children is 100% because the stent itself doesn't grow. In adolescents and adults, where you can put in a 20 millimeter or larger stent, the restenosis rate is very low. Complications, again, procedure-related death, less than 1%, aortic rupture, less than 1%. Aortic aneurysm may happen, especially if you use bare stents, and the stent may migrate, and that depends on the skills of the investigator. The femoral artery stenosis or occlusion is also a problem, as well as in the balloon dilation. If you compare interventional techniques, balloon angioplasty needs smaller sheaths, and growth of the vessel after that is possible, and you have no foreign material. You have a higher rate of wall injury and a higher rate of restenosis. Stent implantation requires larger sheaths, and the stent itself cannot grow, but you can repeat dilation and make the stent grow that way, but it's needed a repeat intervention. I show you the last case I prepared for today. Classic coarctation can, if it's not readily recognized, and this child was also already 11 years old, develop into atresia, and also this can be addressed interventionally. You see here that's complete atresia of the isthmus. I wouldn't call that an interrupted arch. You then have to define the lesion better and can do a needle perforation, and then you have a coarctation, not an atresia anymore, and can put in a stent. We left this stent intentionally with this residual gradient to grow in, and we will do a repeat dilation after 1 year to get rid of the residual gradient and make it a good vessel without this hourglass form. Sorry. Special considerations we need for premature babies, for neonates and infants less than 3 months old. We have good initial results, but the balloon has a high restenosis rate of 40 to 50%. And the restenosis rate is depending not only on the calendarial age, but also on the gestational age, on the time of the duct closure, on the type of the stenosis. And of course, if you put in a stent in a small baby, you will have restenosis related to growth of the child, but also to severe intimal proliferation into the stent. And of course, in small children, you have a higher rate of femoral complications. Special considerations in Turner and Noonan syndromes. We heard about it yesterday, that the wall of the aorta is not okay. So there is an elevated risk of aortic dissection, of aneurysm, and of rupture. And individual decisions are required in every patient, but also in those patients you can either balloon dilate or stent. I want to go to the surgery now. Comparison of intervention and surgery is very difficult. There are no randomized trials. Every case series is pre-selected different. There is an historical development of techniques on the interventional and on the surgical side, and the focus is on different aspects. And there's one more thing. I don't know whether you can read it here. That's a large series presented in JACC. And here, that's what I want to show you. While aortic wall injury is well documented in ballooning and in stenting, because you do an angio after the procedure, the authors write, aortic wall injury in surgery unknown, dissection unknown, aneurysm unknown, femoral artery problems unknown, and here down there unknown, as those types of complications are not routinely evaluated for surgical patients. So nobody cares. If we go to another, this is a good overview on complications. so you see here, of course, restenosis, that's the orange circles, is higher in balloon dilation, up to 53% in the series of Zurich. Walter Knirsch made that. But there are also some surgical series with 25% of restenosis after surgery. And of course, there are, 21, I'm sorry, 21%, not 20, and 24% in some stent series because they put the stents into small children. We have aneurysm rates of up to 35% in some balloon series, but up to 25% in some surgical series. So that's completely comparable. If you go to one of these studies, we see intervention and surgery in children older than 1 year, same pressure reduction, procedure-related complications during the hospital stay, 50% in surgery, 18% in intervention, hospitalization time, 1 day in Germany, I would say it's a little bit more, it's 48 hours normally, and 7 days in surgery. Re-intervention rate, of course, is higher in the interventional group, but we can do re-interventions and get rid of the residual problems. The AHA recommends transcatheter balloon angioplasty at a gradient of more than 20 millimeters mercury and suitable anatomy irrespective of patient age, and stent placement in recurrent coarctation, or if the patient is, the size of the patient is sufficient for safe stent placement. So my preliminary conclusion, before we hear the surgeon, is in classic coarctation, balloon angioplasty and stent implantation are adequate tools for treatment. Do we need still a surgeon? Not for that. No. The surgeon can treat other patients in this time. Thank you.